Good morning, and thank you for everyone joining. We just have a few minutes before we're going to begin the bifurcation webinar series. We're letting everyone join in now. We'll start in about 2 minutes. Thank you.
You're also going to be a LinkedIn and Twitter live. Is that correct, Alan?
That is correct. It'll be live streamed as well.
Do we have the link of this live stream?
The live stream is going to be playing on all of SCAI's platforms on X, LinkedIn, and YouTube.
But do you have the link? Can you share the link of this in the chat?
Alan, okay to go live now?
One more moment. I'm just sending all the links to the hosts and panelists now if they'd like to distribute them. And I believe we are good to start. Let me go ahead and put on the intro slide and we can begin.
Good morning and good afternoon in Europe. This is Tanvir Rab, host of the SCAI Bifurcation Club second year webinar series. I'm from Emory University, Atlanta. It's a pleasure to have members of the European Bifurcation Club with us today. So we will have Dr. Louvard, who's the founder of European Bifurcation Club, Dr. Borzota, who represents European Bifurcation Club, Manuel Pon from the European Bifurcation Club, and our co-host, Yanis Chitsatsis, who's the president of the SCAI Bifurcation Club, and our good friend, Don Abbott, who is our co-host. Ably helped by Alan Gwen from SCAI, and our chat moderator is Pratik Sanasara, an early career faculty member at Emory. So next slide, please. These are disclosures. Next, please. So we'll go through a brief introduction, followed by a presentation by Francisco Barzota about recent updates from European Bifurcation Club. Then a case presentation by Dr. Louvard on the current EBC approach to left main bifurcation, and for non-left main bifurcation by Manuel Pon. Next, please. This activity is supported by an unrestricted grant from Medtronic. Next, please. The CME is available for this webinar through SCAI. Next, please. And here's the link. So without much delay, we will ask my co-hosts, Dr. Don Abbott and Dr. Chatzazis, to give a brief introduction. Yanis, I can't hear you. Can you turn the audio?
Dr. Abbott, would you like to start first, please?
Welcome. Well, I just wanted to welcome our colleagues from the European Bifurcation Club. I think the premier documents that have been published from the group have been appreciated worldwide. I'm looking forward to the discussions and cases we'll have tonight, and how we can engage everybody throughout the world. Thank you for coming.
Welcome, everybody, from my side as well. We're all thrilled today. It's a glorious start of the SCAI Bifurcation Club webinar series. What better than starting with being together with the European Bifurcation Club, a think tank for that over the last 20 years. This year we celebrated 20 years. We have been shaping the field of bifurcations worldwide with concession statements, papers, a real forward-thinking organization. Dr. Vard is here, Dr. Buzot is here, Dr. Pan is here. We talk about people who are legendary in the field, and we're so thrilled to have them with us here today, all together, an online family, a global family, to discuss about the latest in the field and learn from the best. A big welcome to everybody.
Thank you. Good morning, good afternoon, and Italy, and please start with your recent updates on from the European Bifurcation Club. Thank you, Francisco.
I'm starting to share my screen. Can you see it clearly?
Yes, we can.
Yeah. Yes.
So I will start with a short disclosure and clear disclosure to this presentation. As the Bifurcation Club is going to have the annual meeting in a few days, my presentation will be strongly incomplete because we are just close to have it soon. So what I can share with you is the fact that as with the kind words of the introduction has been stated, we worked a lot in trying to standardize, and we have ABC recommendation for the research that are very important, that have been published recently in JAC and in your intervention simultaneously, in which it is standardized how we need to design the trials in order to make the findings be comparable. So it is very important because bifurcations are all across the coronary tree. So every time we put a stent, it is possible that some branch will be aside. So it was an enormous effort led by, honestly, the idea by Yves Blouard trying to standardize this. And I think that this will affect all future trials in the field. Other aspect, probably the most important, at least for the group of the BC, the native group that is very focused on the clinical practice, what we have alive is a series of recommendations that are still, let's say, confirmed, discussed day after day, year after year by the group. And they, cover all the aspects of clinical practice. And probably the most important thing is the fact that the idea of Yves Blouard, the pioneering idea, was that it was important to standardize the concept that when we start a PCI, we implant a stent in a bifurcation, but we should have in mind the fact that it is possible that we will do many other manipulations. And at the end, there are some sequences that have recognized publications, efficacy, and problems. So this is very important, actually. And one of the aspects that came more recently out is the fact that any kind of technique you are trying to practice is associated with specific drawbacks and possibility to have some complications. And it is very important that the operator that starts embarking in a procedure with a technique knows the potential pitfalls and knows how to fix in the case they happen. This is very important and was the objective of two different papers that appeared in 2023. So if we come back, however, to this scheme, what is actually very clear is the fact that we should recognize all the time the fact that the bifurcation is made of at least 3 segment area where the diameters are different, and this complicates when you have trifurcations. So it is important that we state that there is no possibility to perform a bifurcation stenting without performing crossover stenting and POT to accommodate to at least the 2 segments. And in this regard, the concept of POT use as ubiquitary in our interventions is associated with the rethinking about its easiness. And now we know clearly the fact that POT is easy, is effective, but we really need to practice this in a very meticulous way in order to avoid the complications that might be associated with a POT balloon that comes too deep or that comes too proximal. So this is so easy technique, effective technique, but deserves dedication into the clinical practice. Other aspect is if POT is enough. So since it is so effective, it is enough for everything. We are seeing more and more cases done with left main stenting with a balloon, a stent crossover and POT done with the big circumflex left untreated. In this regard, we do not have many data. There is very important effort by the European Bifurcation Club investigators, together with other people that performed the KISS trial, in which the patients with Medina 001, different bifurcation, excluding Medina 001, have been randomized to no side branch intervention and side branch intervention with the kissing balloon or pot side pot after having jailed the side branch and performed effectively POT. So in this trial, what we treated is a type of bifurcation that was not so complex at the end, and we had branches that were not so big. You see that the distal main vessel was 2.3 around, and the side branch 2 millimeters on average. So this means that these are clearly not measured bifurcations in terms of territory of distribution. And now we know that up to 1 year, there is no benefit for systematic kissing. So POT is enough, and when we are dealing outside the big bifurcation, it can be enough if properly done. Anyway, we also recognize the fact that there are biological processes that we didn't know before POT was promoted. For example, this is the problem of neointimal growth documented by a Japanese colleague 3 years after jailing a big branch and not performing kissing balloon inflation. So POT only has the potential for fenestrated ostium restenosis. It has been recently described, but it is increasingly reported in clinical practice. This is an example of fenestrated bifurcation into a circumflex. This phenomenon takes years to happen. We do not know how clinically relevant it is, but it is something that should be, let's say, took into account when we have big bifurcations like left main. So for sure, we can be happy just performing POT, but there is a subgroup of patients who deserve the treatment of side branch. And in this regard, we have recognized the fact that after having performed crossover and POT, we have several ways of performing additional interventions into the side branch if it is needed, and eventually implanting a second stent. And this is now called as stepwise provisional, that translated the concept of provisional as one stent to a technique that is also suitable to treat it with a balloon the side branch and eventually to implant 2 stents if needed. And what we cannot forget is the fact that the isolated side branch dilations is associated with this deformation, systematic deformation into the main branch. So this is probably something that can be done only in selected cases or with specific sequences of manipulations. On the opposite, what EBC recommends is the fact that in the case of need for performing side branch dilations after POT, we perform distal rewiring, kissing balloon inflation, and RPOT. And this is associated with the last drug-eluting stent platform we have in the cath lab, in the cath labs, with this fantastic deformation of the side branch, the side branch ostium that is very suitable for treating the side branch. And this opened the door to the possibility to use the provisional also in an inverted way when we have this isolated disease into big branches. So in this condition, we will use this as the main vessel, and the result in a patient like this can be as good doing this as that. For sure, before leaving jailed a LAD and ballooned, it is very important to check by imaging. In this case, it was done by OCT, and you find that it is fantastic with the very nice absence of any stent struts and the good ostium of the circumflex of the LAD that is confirmed to be stented with the stent coming from the circumflex. This is fantastic to see. So finally, this is effective, but how to approach complex and high-risk bifurcations? When we have lesions by that, especially in unstable patients, I mean, I think that we should be open to implant two stents. And in this regard, we, as the group, recognize the fact that the most important thing in the planning is to evaluate the branch risk, the risk of occlusion. So, and the provisional flow is suitable to implant two stents in the case we are not concerned about the loss of a side branch, the loss of a side branch. On the opposite, when there are major concerns, we can use decay crash, but we may also consider the inverted provisional approach. Regarding decay crash, why a lot of discussion among the group? Honestly, we have the trial, but even if you see the main editorial performed by US physicians very open to decay crash, you will find we proposing the use of decay crash and this in the left main bifurcations. It was clearly reported that in the trial, the operators required to be primary operators for more than 300 PCI per year for 5 years and more than 20 unprotected left main PCI per year. So huge amount of volume. So a technique that is so complex can be cumbersome in the hands of less experienced operators with this kind of lesions. And this is why if we remove decay crash and we consider all the alternatives, it seems that this can be something that can reach the vast majority of the operator's experience. So, for example, in my cath lab, this kind of case has been first pre-dilated. At this stage, branch risk occlusion has been evaluated. Since LAD was worse, this was the operative main vessel, and then the procedure has been performed with a very nice angiographic result. In the case of opposite result, the stent would have been implanted in a sequence that is the opposite. So in this regard, it is very important that if we are using the flow of stepwise provisional for this kind of complex lesions, it is important to be prepared. And in this, Manuel Pan did a very effective job with this paper in which all the advanced techniques for prevention and rescuing of the occlusions of the side branch have been applied. So this means that provisional is easy when the lesion is easy, but when the lesion is complex, provisional may require dedications and technique knowledge by the operators. And with which results we have the BC main, in which these techniques have been applied in lot of 467 stable and unstable patients with big bifurcation, both branches more than 275, type 111 or 011, randomized to stepwise of systematic dual stenting. You see that the European operators used as most the provisional way in the two branches, I mean in the two in the two arms of the trial, either for systematic dual or stepwise. And what we know is that not only the 1 year results, but now also the 3 years results are at least the same, with a strong tendency to better outcomes for provisional. And what is interesting is the fact that when we split the data according to the side branch disease length in the circumflex, we see that with the dual stenting performed like that, there is no difference. So it means while for provisional, there is a detrimental, let's say, clinical outcome in the long term in the case you are handling the patients. For me, this means that two stents are really needed in some patients, but the flow provisional may allow you to have same and comparable results. Last thing is, what about imaging? In Europe, there is a very important, let's say, discussion about the fact that in the new guidelines for chronic ischemic syndromes, class 1A has been given to the true bifurcation left main. So we are happy for that. In the meantime, what is very important is the fact that we recognize that in the absence of imaging, the operators should follow even more strictly all the technique steps we know, and any kind of operators should be really open to switch to the use of imaging in the case a procedure is not following the anticipated outcome. Thank you for your attention.
Thank you very much. I think in the interest of time, Francis, that is excellent. In the interest of time, I'll let Yanis introduce the next speaker, which is Dr. Louvard.
We are very excited to present the spirit of the European Bifurcation Club. The founder and our father, in a sense, of the bifurcation is Dr. Yves Louvard, a true legend in the field. And without further ado, let's just go directly to the lecture. Hello, Yves.
Hello. So you have my talk.
Yep. And so we will begin this now.
To the sound, please.
Is the audio not running? Alan?
Sorry, is the audio not playing? Were you able to hear his audio?
I can't hear the audio. Play. Go ahead, play it. Let's see what happens. No, the audio is not playing. Yves, do you want to talk through this now?
Okay, I'll try. Yeah.
Okay.
So you will push the button, huh? So the patient I will present you is a male patient, 77 years old, with hypertension, dyslipidemia. He has a stable angina, and the diagnostic was completed with the stress MRI, showing 6 or 17 segments in anterior wall, ischemia in anterior wall. Without, go to the next picture. As you can see that the left ventricular function is perfect globally and in anterior wall. Next. So this is my case, which is a 111 lesion on left main LAD and bifurcation and circumflex artery. You can see also that there is a total occlusion of the mid LED, which is short. Next. And also a tight lesion in the right coronary artery proximal segment. So my global strategy is to use interventional for all lesions, because the CTAC score 2 is in favor of PCI without staging, because the patient has a normal kidney function. And be back, please. Sorry.
Go back.
Normally you have the sound, was registered, yes. Yeah. So the kidney function is normal and the CTO is simple. This is double radial, something we do nearly exclusively in Massy. And I use a 7 French in case I need an IVUS guidance. Next. So the procedure began with the implantation of the 3.5 by 22 Resolute Onyx stent. Next. Was completed by a post dilation with the 40 NC balloon. Next. And this is the RTA result. You can see that there is collateral filling to LED. There was also collateral filling from LED to LED. So regarding the CTO, go to CTO, please. Regarding the CTO PCI, this is the CTO score is 2, calcified with blunt occlusion and less than 20 millimeters. So this is considered a simple lesion. Next. So this is a double injection. And I use the local injection with a microcatheter close to the occlusion. And I discovered some channel. So my first wire was a Fielder XT, which one didn't cross completely. So I changed for a Gaia first. Next. So the Gaia first crossed very easily the occlusion. Next. The lesion was pre-dilated with the 2.0 TEG balloon, completed by implantation of a stent, and Onyx 275 by 34 millimeters, by 34 millimeters. Next. So you will see that the result is okay. Maybe you can go back to see the result here. Sorry. Push, yeah, okay. So the result was excellent on the occlusion. So now we are facing a left main PCI 111. This is moderately calcified, and this patient was randomized to double stenting in the study EBC main, presented by Francesco. So my technical choice is, as usual, a T with 2 stents or a TAP. So here is just to go to the next. Just to remember you that the coronary tree is a pseudo-fractal geometry with modulus being the bifurcation, repeated and repeated, and this is following a law, which is the fineness law. We can also speak about Murray's law or Guo-Kassab, but the fineness law says that the proximal diameter equals the sum of the 2 distal diameters multiplied by 0.678. So this is important, this anatomy, because this is a functional anatomy related to the between diameter, length, flow, and myocardial mass. So very important to respect this. Next. So you see here very well the left main stenosis, the LED stenosis, a bit less well the circumflex that we see in this other projection. Sorry. Probably all know now that the QCA is systematically undersizing the diameter of vessel by 5%. So we know that. So of course, this measurement can be corrected for the choice of balloon. Next. Another problem with QCA, on the left, we have a non-dedicated with a regular linear tapering of the diameter function, and this creating some mistakes for calculation close to the bifurcation. On the right, you have a dedicated bifurcation QCA, which is corrected the problem I described before. Next. This is the measurement of my I don't have the QCA. The measurement of the three lesions has to be you have to choose from this measurement the expansion of the stent we'll implant. And of course, as we know, this is the wrong diameter, so we can correct it. So push the button. Yeah, so you can see that we can use this corrected measurement to select your balloon. Next. Very sorry for this, but okay, this is a company chart of pressure diameter, and you can see that when you use an independent analysis, this balloon is inflated one time. When you inflate one time, this balloon is smaller than the company curve. When you inflate second time, next, the curve is oversized, is overlapping the company curve. If you inflate a third time, then the company curve is much bigger. So this is the reflect of not only the elastic nature of a balloon, this is to dilate, but also a plastic nature of the balloon, which is changing by inflation by inflation. Next. And another problem is that, of course, all the balloons are different from one company to another, and they are not giving us this chart. This is independent. Next. We can also use the finesse formula to calculate one of the diameter in a segment which is diffusely diseased. Like here in this left main, we can get the third diameter. So the beginning of the treatment was done with predilation. Next, and implantation of the Onyx 3.5 by 26 from left main to LED. We, of course, with 2 wires. Next. This is the curve of stent expansion. You can see on the left that the stent begin to open at 0.5 atmosphere. On the contrary, if you look at the right, you have typically the curve of a calcified lesion. Of course, this is important to use a high pressure non-compliant balloon exclusively if you have not prepared correctly your lesion before stenting. Next. It was proposed last year by Dr. Ikichi to choose the crossover stent not from the distal side branch diameter. Here is the 3 millimeter, but with a stent close to the proximal diameter. And if you with a very low pressure inflation of a 40 in the 3 millimeter side branch at 5 atmosphere, and after that followed by pot and kiss. And if you look at the bottom right, you see that using a bigger platform, you have a better expansion and probably better delivery of the drug. Next. Okay, you can use also a maneuver to confirm that the flow is interrupted. You inject during the inflation of balloon or inflation of stent. You inject some contrast, and if you see the contrast going distally, it means that the stent is not deployed. This is not IVUS, but this is a small technique. After that, next. After implantation of the crossover stent, you have to do immediately a kiss pot. Here with the 4.5 by 12, not only distally, but you can see distally the distal marker has to be in front of the carena. Next. Yeah, in our place in Massy, we are using systematically by default, the nurse is doing that, inflation of 30 seconds, 2 or 3 times. And of course, for left main, it can be a bit long sometimes. So you can add several shorter inflation just to get the full expansion of the balloon. Next. So this is the result. Video is not going. Oh. Was working
Video play.
yesterday. So maybe go to the. So we see normally on this picture that we have two diameters. The conflict is not occluded. Next. Whoa. So yeah, just back for the three wire, just back here. So just before the one before. The slide before, is possible or not? Yeah, for when we are dealing with the left main, instead of exchanging the two wires to put the main vessel wire in the side branch, and the contrary, it's better to introduce a third wire. And we do that by with a loop and then a pullback technique to re-enter the circumflex artery. This was done. Of course, after that, you remove the gel wire. Next. Next. I'm very sorry. After that, you have to position the stent in the side branch. Remember, it was randomized for a double stenting. So this is the position perfect for a T-stenting. This is not tap, no protrusion, because we pushed some metal inside the side branch. After that, it was inflated in very good position, as we can see here, in an excellent projection. And after that, this is followed by a kissing with two 3.5 diameter balloons. You can see that the overlap is situated only in the polygon of confluence to avoid ovalization of the proximal segment. Next. So we have the final result, fortunately. This is one projection. The second one. Next. Ah, no. Go back to the two last ones, please.
Apologies, I will begin that in just a moment. There was some technical difficulties.
I don't understand. What's working? So during that time, if you go to not the last one, just the previous one, this final, this one. So if you can make it working, we'll see that the result is good. And I've not used any intravascular imaging. And go to the last, to the next picture. The patient is. Yeah, you see the result here without IVUS. And next. So it was for me a very special case because it was my last case in a cath lab. And it was a triple vessel disease, left main and CTO at the same time. So I will remember it was arranged by one of my colleagues. Thank you very much for your attention and sorry for technical problems.
Thank you very much.
Yes, I do apologize. The slides will be available online after this meeting, so you'll be able to go through and watch everything and hear Dr. Levard speak through his case from the videos that he has supplied.
Pratik, any chat questions from your end?
No questions. There's a comment emphasizing the importance of IVUS for left main interventions. I guess I do have a question going back to provisional stenting.
Yeah, you mean for sizing, I used a QCA and modified with 5% additional diameter. And if you can have a 3D QCA, we have the CERC close to us, so we can have this data. And after that, you choose that to select your balloon on the curve.
Got it.
Also, I have a couple of questions here, just to give an opportunity to Dr. Louvard to clarify some things for the audience and highlight them. Number one, you mentioned something, a couple of interesting things. Number one, you said that when you have left main to LED, left main to circumflex, you select a little larger stent than the actual diameter of the LED or the circumflex. If this is the case, how high you go? Let's say you have a 4 or 5 left main and a 3 OLED. What stent would you choose in that case?
Following the position of Dr. Ikichi, I will probably go close to the diameter of the left main, because it will, especially if it's angulated. If you are going to an angulated vessel like circumflex, the stents are floating in the bifurcation. If you use a too small stent, of course, if you use a stent which is too big for the distal bed, you have to inflate at 5 atmosphere. The stent is open, is on the wall for sure, and after that you complete at the normal size of the proximal segment with a pot. And after that you have a better extension of the strut. There are no more floating in the middle of the bifurcation, which is important. And after that we can complete with a second stent if you need.
So again, to highlight this, Dr. Louvard said that we select a little larger stent, larger than the distal reference, to make sure that we're going to have better scaffolding of the whole disease segment. Of course, that stent distally, to avoid dissection, should not be inflated in nominal atmosphere, should be inflated in low atmosphere.
You have to inflate under the curve at 5 atmosphere. And I have to say that during the EBC next week, we will have the clinical result of this practice by Dr. Ikichi. So I don't know is the result.
That's very interesting, and a little bit of a change in practice here, because we used to say just stand religiously to the distal reference, not an inch, like not a millimeter above this or below this, of course. And then the second point I would like to highlight very briefly, to ask actually Dr. Louvard here to clarify, is the pot. You mentioned that you routinely we used to do the pot starting from the carina all the way proximally. Do we have any different approach now on how we do the pot in a long proximal main vessel stent?
The rule when you are stenting is to have the balloon inside the stent. So if you choose the short balloon to do the pot, you may have to go back to the proximal part of the stent the second time. But what I was insisting on is when you do the pot, you have to put the distal marker of the balloon on the carina, in front of the carina, not too distal, because you will push the carina and close the side branch, and not too proximal, when the cell won't be open in the polygon of confluence. So you have to use, is depending the balloon you are using. If the using is good, the balloon is good for the whole length of the left main, this is okay. If you use a short balloon, you have to manage from distal to proximal, or Dr. Ikichi says sometimes from proximal to distal. So we will see the result next week.
But we continue with the traditional approach from distal to proximal if we have to use shorter balloons. And then third, quick last point, you said that in Massy, you used to inflate every stent 3 times. So you inflate once, and you inflate again.
It's true for the treatment of a second diagonal, the right coronary mid-segment, a PDA, is true for the left main. The nurse has the information to inflate 30 seconds. So we inflate one time, we say 13 atmosphere because this is the diameter, and we deflate after 30 seconds, we don't ask. She inflates a second time, and then she inflates a third time. Of course, for a left main, you may have to adapt this, because, the case I presented was collateralized from the right, especially because I treated the right first, and I'm convinced that it's possible to inflate 30 seconds a balloon inside such a left main. But in most of situations, you may have to inflate 4 times, 15 seconds. And you have relay papers on that. The reference is Skowronski, SKOWRONSKI is the reference for this. So you will find that in literature.
Thank you.
All right, in the interest of time, I'll let Dawn Abbott introduce our third speaker.
Yes. So the last talk will be given by Dr. Manuel Pan, who's a professor of cardiology at the Hospital University of Reina Sofia. I guess that's after Queen Sofia. He has over 500 publications and very well known in bifurcation circles. So we're excited to hear your talk. Thank you.
Thank you. Thank you for your presentation. Okay. Thank you for the invitation. It's a pleasure to be here sharing with you our experience in bifurcation. As previously has been mentioned, during the last 20 years, many basic consensus have been published. In this document, a lot of recommendations, tips, and tricks has been provided in order to perform a correct provisional stenting technique. For this presentation, I have prepared two cases in which we will analyze the current EBC recommendation based in these previous publications. Next. My conflict of interest. Next one. Next slide. Okay. This is the first case. Is a LAD diagonal bifurcation lesion that was guided by IBUS. In the angio, you can see that the bifurcation is 111 from Medina, and the baseline IBUS provide interesting finding in order to plan the strategy. On the right, you can see the IBUS image. It was a forward registration. So in the tip, you have the proximal more healthy segment. In the middle, the proximal diseased showed a soft plaque, no lot of calcium, seems to be a plaque that don't need very aggressive preparation. In the bottom, the more distal part of the lesion with the same IBUS characteristic, and finally the distal healthy segment. So the information from the IBUS is first about the size of the vessels. The distal size is 2.75 millimeters of diameter. So it's interesting in order to select the size of the stent. And the proximal is 3.5. So also an interesting information in order to select the balloon of pot. Again, the characteristic of the plaque suggests that not aggressive preparation is needed. Next slide, please. So the strategy was a provisional stenting, classic provisional with an stent across. The stent is implanted across the bifurcation, 2.75 millimeter, with the use of the gilded wire technique. The gilded wire technique has been recommended in most of the consensus paper. This is the 17 EBC consensus that summarize the prevention of the cyberarm occlusion. The classical is the gilded wire, but you also can use the active protection with a balloon, the gilded balloon technique, described by Francesco many years ago. But this is a simple bifurcation, and we thought that with the classical J-LED wire was enough. So the stent was implanted across the bifurcation, then pot according with the size of the proximal vessel provided by the IBUS, 3.5 millimeter, and also the cartoon that has been previously presented by Francesco. I like a lot this cartoon that describes the correct position of the balloon in order to perform the perfect pot. The image of the stem booth is on the bottom of the slide that seems to be correct, with a different diameter between the distal and the proximal stem according with the pot. Next. After the main vessel stem implantation and pot, you can see a severe compromise of the side branch. So we again consult the recommendation of the EBC consensus. This is the 16, and if after main vessel stem implantation and pot you have a severe compromise, you need a rewiring of the side branch in order to perform a kiss. If the kiss obtain a good result, the procedure is end, and if not, you have to implant a second stem. So we will continue with the provisional philosophy. Next. This is the moment of the side branch wiring. For the side branch wiring, sometimes it may be a difficult maneuver. You have to use dedicated devices, but in this case it was not. It was relatively easy, and only two recommendations. First, pre-shape the wire. That in most of the case is enough in order to successfully wire the side branch. If not, you can use a stiff wire, even CTO wire in very difficult case, in calcified lesions, or the dedicated devices. The recommendation that also has been presented by Francesco in the previous presentation is to access to the side branch through the distal strut of the main vessel stem. For this maneuver, it's useful to pass the wire distally and then remove slowly the wire in order to reach the ostium of the side branch, as you can see in the video. Next. The kissing is performed again according with the EBC recommendation. That should be a non-compliant balloon, short non-compliant balloon. The size of the main vessel according with the diameter and the size of the sabran again equal. So you have to use the same balloon, the same diameter in non-compliant balloon. The image, the deformation of the stem obtaining with after a correct pot and a kissing is very favorable, as is similar to this cartoon published by the ABC, the Francesco white paper in 2020. You can see that if you perform all the maneuver in a correct way, you produce a favorable deformation of the main vessel stem in order to access the side branch. The stem booth is similar to this ideal deformation of the main vessel stem in the access to the side branch. Next. This is the final result. The angiographic result is excellent in the video and in the frozen image. And next slide, please. The IBUS also showed a good result in terms of stent expansion, stent apposition. The stent is well apposed along the stent segment. This is a pullback from distal to proximal LAD, and the minimal deformation that could be seen in the stent booth in a favorable way. In the right, you have the longitudinal reconstruction that demonstrate also all this good result with a good access to the side branch. Next slide. The second example is a case in which we use the physiology to guide the procedure. The EBC also published recently a consensus paper in collaboration with the Korean and Japanese bifurcation clubs. The physiology is not frequently used in bifurcation. Operators normally prefer the image, but this is a very interesting case, as you can see. The case is a right coronary artery with a distal bifurcation lesion 1-1 from Medina, and the initial strategy before the physiological study was one stent across the bifurcation toward the PLA oriented, and then a pot, and see what happened. Next. This is the central illustration of the consensus that recommend the use of physiology, mainly when you use provisional stenting in order to evaluate the result at the side branch ostium. If the result from an angiographic point of view is good, nothing is recommended and stop the procedure. If the ostium of the side branch seems to be compromised by angio, and physiological study using the FFR or a non-hyperemic index is recommended in order to evaluate the flow at the side branch. If it reduce additional intervention of the side branch is recommended, and if not, stop the procedure. Next. But in this case, we use the non-hyperemic index, the IFR. Echo registration with the angio is very useful. The red dot indicate the concentration in the segment that contribute to the reduction of the flow. This is the first pullback from the PLA to the proximal right coronary artery, and you can see a very severe lesion in the proximal part of the bifurcation. When you repeat the same pullback from the PDA, you can see the same in the proximal segment. You can see the same finding, but an additional concentration of point in the origin of the PDA. So the origin of the PLA is free, seems to be not no compromise, and the origin of the PDA demonstrate a severe lesion from a physiological point of view. Next. The Medina classification was described 20 years ago and has the limitation of the angio. Medina classification is based only in angiography. But during these years, many additional techniques to evaluate bifurcation have been used: image, physiology, CT, QCA, etc. And Medina classification survived to its limitation, and all this additional technique used for the evaluation of the bifurcation adopted the philosophy of Medina. So we have Medina Echo, Medina IBUS, Medina CT, Medina QCA. But in the case of the physiological study, the physiological study has a limitation in the evaluation of a bifurcation, because when you put the distal tip of the wire in the main vessel, you have evaluating the proximal and the distal segment simultaneously, and equal occur when you evaluate the side branch. You have the combination of the proximal and the side branch origin, and it's difficult to evaluate the contribution of each segment to the limitation of the flow. But with the use of the co-registration and the IFR, you have in the previous slide, you see that each segment is clearly identified. So when we talk about the Medina angio, in this bifurcation is a 1-1-1, but have to be reclassified after the use of physiology, because the origin of the PLA have not a concentration of points, so it's 1-0-1. These findings help to determine who is the mother and who is the daughter, a change of a strategy, and in this case, we changed our strategy to inverted provisional, and the stem was oriented, next slide, to the PDA instead of the PLA in order to cover all the diseases segment. The result, next, is shown in this slide. You can see an excellent result after one stent across the bifurcation and pot without kissing toward the PLA, and the angiographic result seems to be excellent, as well as the physiological study with a negative IFR in both branches, in the PLA and in the PDA. Thank you for your attention.
Thank you very much. So I'll ask the chat moderator to see if there are any pertinent questions, and we might be over a few minutes, but Pratik, do you have any questions?
There's a question from the chat going back to left main bifurcations, asking how often do most operators actually hit the latest MSA targets of 8, 10, and 12 millimeters squared for the circumflex, LAD, and left main?
This is
Dr. Vargas.
you are speaking about 6, 7, 9, and 6, 7, 8, and 9.
Yeah.
10, sorry.
The question is,
yeah, there is the real problem of sizing. You have the sizing following the work coming from Korea, the group of St. John Park, 5, 6, 7, 8, then modified for Excel 6, 7, and 10. No, 7, 8, and 10. And now you have a new one in January, which is 5.7, 6.8.3, and 11.8. So this is changing continuously. So a second option is to measure the percentage of deployment of the stent inside the external luminal membrane. And I raised another problem, which is maybe why not using the fractal ratio? I mean, try to have to follow the rule of Gérard Finet. So we are working on this. So today, I don't know what to tell you. In Korea, they said that they use 11.8, 8.3, and 5.7, but this is for whole population. This is not possible. You know, they have big people, they have small people, like everywhere. We cannot use such a rule. For me, it's completely impossible. So you can go from, if you have some segment in your bifurcation which seem normal, are normal with IVUS and OCT, or seems normal with the QTA, you can calculate the diameter that you will be your objective. I tried to develop that in my talk, but it was a bit perturbated. So it's difficult, especially when the disease is is in the 3 segments. It's very difficult to size the stent properly. So it's a good reason for using intravascular imaging, for sure. But I've not shown intravascular imaging in France because we don't have it. We have 5%. So, of course, I can show that during a live meeting. But 95% of others are treated without intravascular imaging. So
Don,
we will have information again. We'll have information next week in Bifurcation Club.
Don, do you have any questions or any comments?
No, I mean, I know we're short on time. I was going to ask Dr. Pan, when you did your IVUS assessment for the provisional, how much do you assess of the side branch in terms of the likelihood of side branch closure? Are you using the angle, looking for an eyebrow sign? Are you using V-resolve scores, or are you relying on any scores? Or, I mean, I guess everyone default has 2 wires, but are there certain IVUS or imaging characteristics or anatomical characteristics you should highlight for the viewers that would be at high risk for closure?
Yeah, I like to use the sign in described by our friend Alfonso Bedina in the EBC. That he called the sign the eyebrow sign, basically in the Casablanca film. It's a crazy story. But the sign finally is an spiky carina that is obtained in a pullback, in a IVUS pullback from distal to the proximal vessel. The carina, if you in this pullback, in this longitudinal reconstruction, see the spiky carina is a strong predictor of side branch occlusion. Was described in one of our previous EBC edition and then published in Neurointervention. And in the last in the 17 consensus we enumerate all the high risk factors to close the savannah. That seems to be useful too.
Yeah, very good. I think, again, always protecting the side branch is helpful, but understanding some of these nuances can really help you predict what's going to happen and be ready for it.
Yeah.
Thank you.
But the beauty here, Don and Manuel, is that initially it looks diseased everywhere, and you plan an upfront two-stent technique. Maybe you go a little more extreme and plan for a decay crash. But by adding the physiology component here, you might downgrade the complexity of disease, and then you might convert this to a provisional, stepwise provisional, and then see how the side branch behaves, which is not physiologically significant, even though it looks diseased on the angiogram. And then you can go ahead with provisional, one stent crossover, and then stepwise to the side branch if there's spiky carina or you have occlusion or any complexity, but knowing that you deal with a not hemodynamically significant branch.
Pratik, any other questions?
Yeah, one question that came in is, during the kissing, the carina area has 2 balloon diameters. Would there technically be a significant oversize in the location?
Yeah,
Well,
but
Francesco.
okay. So honestly, there is the presence of 2 balloons doesn't mean that the final diameter achieved during the expansion is exactly the sum of the 2 diameters. There is a very old Japanese study in which they reported with the balloons that we had at the time, and there is the possibility to estimate. So overall, we should not, it is true that we have the risk of oversizing, but this oversizing is not as high as expected by the diameter, the sum of the 2 diameters. And one trick to limit this overexpansion is to do not perform kissing balloon inflation at very high atmospheres. And this is why we suggest to perform sequential kissing, in which we go high atmospheres with the balloon in 2 directions isolatedly, and then we inflate at normal atmospheres for kissing balloon inflation. These are the tricks.
Well, we are getting close to, we've gone over time. So thank you very much to our European colleagues, Yves, Manuel, and Francisco, and to our US colleagues, Yanis, Don, and Pratik. And also thank you, Alan, for taking out a Saturday morning I hope this works well with the European group because it was difficult for them to join on evening time. So we'll carry on when we invite you next time to keep this Saturday in mind. So thank you very much, and hope this was a good meeting for you all. See you all in the
Thank you. Thank you.
Thank you.
Bye-bye,
Bye-bye.
everybody. See
See
you
you
all
in
next
See you in
week.
the club.
See you
See you in the
in
club.
Frankfurt.